everyone. I know we have a small group right now, but I imagine we will get more as the evening goes on. Nate, it's good to see you. Welcome to the August Alumni webinar series. We're privileged this evening to have the talented Dr. Nate Sowa with us. He'll be discussing virtual care. Nate is a clinical assistant professor at UNC currently, and he is the inpatient psychiatric consultation liaison service attending, one of them. In addition to his job with the CL service, he does outpatient CL work with some of the residents in one of the training clinics, as well as works with family medicine department and others in some of our collaborative care model clinics. Nate's probably one of the busiest guys I know at UNC, more so now than ever, I imagine. He's talking about virtual care, which is a topic near and dear to many of our hearts who for people who are doing outpatient services, and I'm sure even inpatient services again here to come when it comes to being safe in the era of global pandemic, political unrest. There's so many reasons for us to stay safe and sound in our homes and have our patients there as well, while still delivering excellent care. So we're happy to hear from Nate. I'm excited to hear the updates and ready to learn about what we can do as alumni to help support UNC's mission and our own patients. Nate, take it away. Good to see you.
Hey, Rachel, thanks. That was a very nice introduction. So I thought, and I apologize, I'm a little under the weather. We have daycare crowd going around our house. I thought I would talk a little bit of structure, and I know I wasn't supposed to maybe structure this too much, but I did put together a few slides. I couldn't help myself. So I'm going to share my screen and oh, it's disabled. Sam, do you know, can you give me that?
Hang on, let me figure that out.
Or I can email you the slides. Let's see.
I just made you the host. See if that works.
Oh, okay. Let's see. Yep, that worked.
Great.
Great. Thank you. Okay. Okay. Can you all see the PowerPoint? Yes. Okay, great. So, so I thought this was sort of how I was thinking about talking through things. And of course, please chime in with questions. I'm opening up the chat now. I want this to, hopefully this can be a conversation. But I thought I'd just talk a little bit about telehealth in general, COVID-19 especially, and then what we've done at UNC during COVID, a little bit about payment moving forward, since that's a big question, I think, on folks' mind around telehealth. And then sort of what we're doing in the department and some of the areas that we see sort of expansion. And actually, I think there's potential for involvement of alumni in some of the work that we're doing. So, you know, I think in terms of history, you know, telehealth has been done in behavioral health for quite a long time, really going back into the 60s. There were folks that were doing psychology mostly, so psychotherapy via telemedicine. And when I say telehealth, telemedicine, virtual care, there's a lot of terms out there that people use that sort of encompasses a lot of the same things. But when most people refer to telehealth, they are referring to use of technology, not just to deliver clinical care, but also education or, you know, use of maybe some ancillary services in health. So it's not necessarily the delivery of a medical service is sort of what encompasses in telehealth. And then telemedicine is the term that we use specifically for medical appointments using virtual technology. But telehealth has been used for quite some time, not just for clinical applications, but also you know, educational outreach, et cetera, in behavioral health circles. It's really been it was really sort of a niche area for quite some time. And then of course, in the past 10 years or so, there's been an explosion in telehealth and in behavioral health as an opportunity to increase access to care. And this was been largely used by private organizations or individuals who, you know, have maybe, let's say, an outpatient practice that they would like to, you know, accept payment outside of insurance, largely because they were either was not reimbursed by most insurance companies, and or Medicaid and Medicare put such restrictions on how telehealth had to be delivered that it really only made sense if patients were paying out of pocket for services or for large healthcare systems who needed a service that they couldn't hire internally for. So the largest areas where people were using telehealth and behavioral health were inpatient or emergency departments or skilled nursing facilities in regions where maybe there was a shortage of psychiatry providers or therapists, and they were paying large sums of money for either locum physicians or other access to care. And so instead, they contracted with private companies who would provide physicians and telehealth platforms and basically provide that care at a loss, but it was such a needed service for them that it made sense. And actually worked for a private organization doing that work prior to coming to UNC for a period of time, serving an emergency department and consults on an inpatient medical surgical floor, again, for a hospital that was located in an area that they just didn't have psychiatrists that they could hire and keep on staff. So that's historically where it's largely been used. Of course, again, in the outpatient arena, I think it's been more largely used for psychotherapy, and there's a lot of good evidence for its efficacy in psychotherapy, really on par with what you get with face-to-face treatment. Of course, that depends on the patient and the type of treatment that you're using, but that's really largely where it's been. Of course, all that changed with COVID when, for obviously reasons, folks were forced to either shut down the clinic or move to safer interactions. And telehealth moved into areas that it was never used before. Of course, in behavioral health, we expanded it greatly because we can do a lot of what we do virtually. And so in sort of surveying folks that I know around the country, most outpatient clinics that are doing telehealth or that are doing behavioral health moved to telehealth almost exclusively initially. A lot of that has backed off, and people are doing more in-person care as personal protective equipment become more available and more people are vaccinated. But really, for a large number of time, virtual care was really how behavioral health was being done most places in the outpatient world. In the inpatient settings, obviously, there was still a lot of face-to-face care. At UNC, we basically went from doing no virtual care to doing almost exclusively virtual care overnight. So this is just a graph looking at the number of appointments and split up by the modality that the visits were being done. So you can see in the months leading up to COVID, the black line is our total number of visits in the department. And the blue line, which is basically, you can't see here because it's just overlaid with the black line, was the number of patients that we were doing in person. We were really only doing a small number of appointments virtually as part of a few clinical studies. And that, again, was largely because, excuse me, we couldn't get paid to do that work for reimbursements through either Medicaid, Medicare, or private payers. So then in March, of course, was when the first shutdown happened. And you can see that we had a dip in our overall visit volume when we were closed down and tried to get things sorted out. And that was when we switched initially largely to telephone visits, which is what's in red. And then over time, really moved towards video visits for most patients, if possible. And so you can see that, by April, we were already doing 70% or more of our visits by video. And then that's continued to grow over time. We've had, in the past few months, especially in July, we've shifted to doing more in-person care, and the video has dropped, but we've tried to reduce the number of telephone visits that we're doing for various reasons. One, they're not reimbursed by everyone at the same level, and there's questions about how efficacious they are for certain types of appointments. whereas video, people feel like they get a better, experience, clinical experience. So we anticipate, sorry. Yeah. Oh,
I think sorry. He's muted. We can make sure we mute ourselves unless you have a question. And also, just as a side, also a good pausing moment. I'm getting some text messages from some alumni saying that they're not able to get in because the host needs to let them in. I'm not sure if that needs to be switched over.
Oh, what does the host need to? I need to let them in. Let's see.
You may have been getting a pop-up should have been coming up saying that someone's in the waiting room. You just have to approve it.
Let's see. Sorry if you guys hear screaming in the background.
That's okay. Let me try to figure this out.
I see 3 people entered the waiting room.
Oh, good.
Yep, I'm going to admit them all. Okay. I think I managed to do that. Okay, let me know, Rachel, if you hear of other folks. Okay, so where was I? So since the pandemic has started, this is just a breakdown of visits that we've done in the department. So we've now done over 74,000 video visits, 14,500 scheduled telephone visits, and then our in-person visit volume has just been around close to 8,000. Whereas we were doing, 6,000 in-person visits a month previously. So we really largely shifted to virtual. And that transition was rocky, I think, initially for many people, as I think the whole situation has been difficult. I will say UNC was not particularly prepared for that level of virtual care when we made the transition. It was really sort of being rolled out at a very small level across the UNC system. And when the floodgates opened and everyone wanted to move to virtual care, they really weren't prepared to do that. And so there was a slow, that's why you can see sort of in March and April, we were doing a lot of telephone visits because we really didn't have the video visit capability ramped up or the processes for how to get that operationalized. So there's been a steep learning curve, as I think it's been true for most people in the space. And so, however, we're to a point now where it's pretty much business as usual for us. We have identified folks that we do think are better served by having visits in person. And so we've that's largely patients who might need physical examinations, some of our geriatric patients, folks who need long-acting injectables, and patients who need periodic physical exams for whatever reason. And then I think for some of our folks working with kids, it's been challenging, especially children with developmental disabilities. That has largely moved back to being in-person care if possible. Of course, with the Delta variant, we're still encouraging virtual, but probably what I anticipate happening over the next 6 months is hopefully we get through this surge and that there's not another one, but we'll basically sort of shift to a model where we will allow patients to kind of state their preference as to what kind of visit they would like to have in the outpatient setting. And then we'll kind of see what happens in terms of how they vote with their feet and the types of appointments they want. What we're seeing from surveys across the country is that probably 40 to 50% of patients are saying that they would keep their behavioral health appointments virtual. So I think just if you all are thinking ahead to what your practice might look like in the future, in terms of what the patients want, it's again will be patient specific, but at least around half the patients in national surveys have said they'll still want the capability to do virtual visits for behavioral health appointments. This is what happened in the outpatient side. On our inpatient units, we did move to more telehealth in certain aspects. So in our teaching hospitals, we moved to try to limit the number of individuals that were rounding face-to-face. And so instead of rounding in teams, there may be one individual that was rounding, seeing patients, and then we would have other folks joining remotely. So I know on the some of the inpatient units at the medical center, they would have patients come into one room, if possible, where they would have a laptop set up, and the person on site would interview the patient, but then there would be additional team members off-site that would be still a part of the interview, but joining virtually. So that was happening, especially early on in the pandemic, where they wanted to limit, PPE utilization and, for patient and provider safety. And so that has shifted now. Pretty much everybody is back doing face-to-face rounding on the inpatient units, but it was a nice capability to have when necessary. And I think it was also a good way to incorporate more people into the team discussions. And so I don't know that I haven't talked to the inpatient folks recently, but I know especially some of the support services, the physical therapy, or the OT, recreational therapy, et cetera, some of those other services actually allowed them to be able to join for treatment teams more easily. On the consult side, we have rolled out a consult service that's virtual to Hillsborough Hospital. So we don't have any providers on site there for psychiatric consults, but we do everything virtually now via video. That is going fairly well. There are definitely patients that would probably benefit from being seen in person by a psychiatrist, but this was the way that we were able to sort of stretch our resources to serve another hospital in the system. And I'll talk a little bit later about how that may be developing even further to try to serve some other hospitals in the UNC system. And then we have launched our electronic consults. We've done about 80, actually it's a little closer to 90 now to date. And that's just a service where, as a primary care provider or a specialty care provider or a psychiatrist that's in the UNC system, can put in an electronic consult where basically one of our providers will review the patient's chart and provide recommendations without seeing the patient. So it's strictly a chart review, and here's my thoughts and recommendations. So it's really a way to sort of formalize curbside consultations for providers if they have a question. And so mostly we get medication questions from providers saying, I've tried this medicine, what should I do? Here was a side effect, what should I do next? Type of question. And we're looking to expand that. We're doing this for both children and adults now. As a result of moving to virtual exclusively, we now have, as I said, 74,000 virtual visits over the past year plus. It really allows us to sort of look at some data that we were never actually able to do before. Telehealth in behavioral health has a pretty strong evidence base around efficacy, especially in the psychological services sector. But it's really never been looked at broadly in terms of how efficacious it is in, treatment of depression, anxiety, other more serious mental illnesses with medication management. And it's really not been looked at with telephone visits. Our telephone visits equal to video visits or not for certain patients, especially because we know certain populations may not be able to do video visits. It's really not been looked at in some of these consultation models where we're doing inpatient consults virtually. That data is not really robust. So it's presented us with an opportunity. We now have a lot of data to sort of dig into and look and see, who are we serving? Did the population that we serve change during the pandemic with our shift to virtual? How we're serving them? Did it change how frequently we saw patients? And did we expand our reach in a geographical sense? Are we seeing patients from different parts of the state that we didn't see before because it was too difficult for them to come to the clinic? And out of that, comes questions about telehealth equity, which is, I think, is a big question, on people's minds right now. This is internal data that I pulled up, just looking at the percentage of patients broken down by race, of what percentage of these patients had video visits as opposed to telephone visits or in-person visits during the pandemic. And so you can see that individuals who identified in our electronic health record in Epic as either Black, African American, or Native Hawaiian or other Pacific Islander have a lower percentage of video visits compared to individuals who identify as other races. And so why the reason for this is not clear. We want to dig in a little bit deeper and try to understand it, but it raises a lot of concerns. There's a lot that's been written recently about how telehealth, could be an opportunity to reduce some disparities that we're seeing in health, but it has to be used appropriately. And just because we think that it's going to increase access, when you dig in, you may actually see, well, there's still maybe a certain type of population of patients that is not going to be able to utilize the best services out there because maybe they don't have access to broadband internet, or maybe they don't have access to a device to connect with the provider, or they have a device, but they don't know how to use it. So can we identify populations that are sort of being left out of the telehealth movement so that we can better serve those populations? I'll talk a little bit about that with some of the projects that we're thinking about now. There's something else I was going to say about that piece.
I have a quick question. In terms of improved numbers, do we have like a comparison of the breakdown and demographics of our in-person visits as opposed to our video? Because I do wonder if this trend is the same or if we're seeing a dissonance or like a divergence from what we were doing in person.
You mean in terms of like the percentage of patients that we were connecting with? Like what was our makeup?
Yeah, like
sorry,
you're going to answer it. Yeah, a lot of the questions of these research questions, who are we serving and how are they utilizing? Yeah. I do wonder what our clinic before looked like, and is that unique across the board?
Yeah, no, it's a great question. We're trying to pull all that data now, and it's a little bit the tricky part for us. I think is this was a forced movement. Everyone was forced into telehealth, which I think is interesting and presents us some opportunities to ask some interesting questions. It's also, I also am a little bit skeptical about some of the data just because we also have to think about the confounding of factors of the mental health just changed in response to the pandemic. So, we know, for example, like we're looking at visit volume, and on the face of it, like we seem to be seeing more patients in the virtual space, which is true, but that's a little bit conflated, and because some people were shifted from inpatient to outpatient work, and our patient volume changed. Do we have a higher turnover of patients coming in and out? We don't know. Like these are some of the questions that we have to sort of dig into and ask. But yeah, that is a big question for us: is who are we serving? Were we serving a different population before? We're serving now. One thing, I was just looking at some child data for a research project that we're putting together, and in the outpatient world, the number of children and adolescents that we saw did go up during COVID. Mm-hmm. And that was largely being driven by adolescents. So if you break down the data at the age 12, over 12 versus below 12, the number of children that we're seeing basically stayed the same, but we are seeing a lot more adolescents. And, I don't think that has anything to do with telehealth. I think it has everything to do with COVID. So, we just have to look at this through the lens of COVID. But that is the question, like, are we serving a different population than we're serving before? I think the other piece is who are the patients that we were serving before, and maybe they dropped off because of telehealth, but there may be other reasons as well. Can we sort of look at the patients that we've lost and see any patterns there and try to tease out, was that because they couldn't engage as well, or were there other reasons?
Nate, if I could interject.
Hello.
Hi, how's it going?
Good, how are you?
I'm good. So one of the things that we noticed in our clinic was many of our African-American patients thought erroneously that their visit would not be covered if it wasn't in person. I don't know how that started, but once we addressed that, we saw our numbers change. And then with many of the folks who did decide to come in person, the first thing I asked was if they had access to the equipment necessary to be successful with the telehealth visit. And even when that was the case, most people reported to us that they didn't have many opportunities to get out of the house, and they felt like it was safe to go to the doctor's office. And so they chose to come for in-person visits.
Yeah, interesting. Yeah, I mean, I think, as I was saying, we in the department basically just didn't have the opportunity. We basically said we're not going to allow for in-person visits, with some exceptions. But I think what I've seen in other places is where they still had the capability, as you say, there's definitely a breakdown. The patients that still utilized in-person more were African-American patients as well as Asian patients. And, the reasons for that, I think, are varied, but I think these are the questions that we need to dig into and try to understand. I think there's also still some, again, like even if you have the devices, like as you say, like, do you have a space where you can sit? I think probably all of us on this call have had an experience now where our patients were trying to have an appointment in a space that really wasn't, fitting to have a doctor's appointment. And so, how do you work around that, especially during COVID, when everyone was stuck in their house with their kids and their, family and whatnot. So
celebrate.
I think it will change a little bit as, again, hopefully over time, it settles out to where the folks who really want to engage via telehealth will be able to do so. And the folks that want those in-person appointments will be able to do so as well.
Just like everywhere you can assist.
Just going to remind everyone to please mute if you're not talking. Thanks. Oops, sorry. So I think those are the main questions I want to talk about there. I want to talk a little bit about payment for telehealth, because I think this is a big concern for folks, right, as moving forward. What's going to happen? Right now, most places are paying for telehealth, but it's not entirely clear how that's going to develop in the future, which is making it really difficult for health systems to plan. I can say at UNC, we are banking on the fact that we're going to continue to have the capability to get paid to do telehealth as a way to expand our services. But that's not really guaranteed at this point. I will say this is just data looking at, this is from our UNC managed care group that looks at private insurances. And, you can see that what's happened is a lot of the private companies are sort of leaving it open-ended and saying, yeah, we're going to continue to pay until further notice. Or what Blue Cross has done is, in North Carolina at least, has said, we're going to continue to pay to this date, but that date can move. And so, it started off being, we're going to continue to pay for virtual telehealth visits until December of 2020. And then that has been moved, and now it's the end of this year. And last time I talked to someone from Blue Cross, they basically said, we still want to have more time to assess who are the right types of patients that we think are appropriate for telehealth. What I'm reading between the lines, I think what they're saying is they don't want to probably allow payment for telehealth for, certain medical and surgical appointments, but but they probably will continue to pay for behavioral health. Again, it's not entirely clear, but that's sort of what my read between the lines is. And, you know, a lot of payers do follow what CMS is saying. And, you know, CMS has basically said, you know, at least for the past year and a half, they have sort of opened things up a lot. And they have come out with a new physician fee schedule that addresses this. I see your question, Ranga, and it varies. So right now, we are seeing reimbursement at the same level as face-to-face from pretty much all of our payers at UNC. I think what we worry about is that will change, and especially in states where, you know, North Carolina is not a telehealth parity state. So certain states do have laws on the books that require telehealth to be paid at the same rates as face-to-face visits. That's not currently the case in North Carolina. There is a lot of lobbying that is going on to behind the scenes to try to change that. But that is a concern, is that they'll come back and say, we'll continue to pay for this, but it's not going to be at the same rate as a face-to-face visit. I will say the American Telehealth Association, which is probably the largest professional organization around telehealth and virtual care, have done a lot of work to look at cost, because what insurance companies historically have said is like, well, you don't have to pay, you don't have as much overhead to do telehealth as it does to have an office space and staff and et cetera to do telehealth visits. And they've done a lot of work sort of on the economic side of things to sort of justify, you know, equal payment for face-to-face care, or, you know, compared to face-to-face care. So I think with the parity laws that are coming down, you know, my hope is that we will still continue to see equal payment, but you know, I think time will tell. So it's a good question. What CMS has said for 2022 as of right now is they're going to continue to allow certain services on the telehealth list to remain until the end of 2023. And that will allow them to evaluate whether those services should be permanently added. Part of those services are mental health services, including telephonic, so audio-only services, which I think is great. And they will continue to pay for audio-only services at the same rate as audio and video services. However, there is one little sticking point, which is that they are requiring an in-person visit by the provider or someone in the same practice within 6 months of that initial telehealth service, and at least every 6 months thereafter. So they're basically saying you can do telehealth. The patient can be anywhere. They can be at their home. They can be in an office. It doesn't matter. You can be anywhere as a provider. You can be in your home or an office, whatever. They've gotten rid of all of those stipulations, but they want you to see a patient before you do telehealth. And there's no real reason for that. There's no guiding principle. There's no evidence that suggests that that's necessary or that leads to better care. And so this is actually something that there was a bipartisan bill. Bipartisan bills do still actually happen in the US Congress. So that was put forward by Bill Cassidy, who's a Republican from Louisiana, as a Republican from Ohio, and then a Democratic senator from, I think, Oregon, or a congressman, Oregon or California. But it's basically called the Telemental Health Care Access Act. And it basically removes that stipulation. That's that in-person stipulation, and wants to sort of permanently expand access, just as how we've been doing business over the past, whatever it's been, seemingly 5 years, but I think just a year and a half, or a year and a few months. So you can see, if you actually Google Telemental Healthcare Access Act, the first thing that comes up is a link to Bill Cassidy's website that talks more about it. The APA has put together some lobbying around this. So if you want to contact your state senator, US senators, I should say, about this act, or your congressman, you can go to the APA website. I can send this link out. They'll send a letter to your senators about supporting the Telemental Health Care Access Act. I see your question, Rachel, about the Ryan Haidt Act. So, so the reminder, folks, the Ryan Haidt Act is an act that was put into place by Congress a couple decades ago now, that was really meant to curtail folks getting access to controlled substances from providers who were other parts of the country. So it really tries to limit prescribing of controlled substances across state lines in particular. It's not clear to me. I mean, right now, some of those guidelines have been relaxed. It's not clear to me how that's going to come back into play. I haven't heard much about that. So I think that's to be determined.
Can I comment on that? Can I comment on that? Because I know the answer.
Yeah, of course.
Yeah, hi, I'm Bruce Hirschfield. I was at UNC from 1971 to 1974, which looks like probably before any of you were born. But I practiced on my farm in northern Baltimore County, about 20 minutes south of the Pennsylvania line, what they call the Mason-Dixon line. The Ryan Haidt, I don't think it's that old, by the way, but it's been suspended because of the pandemic. So you don't have to see someone in person to prescribe a controlled substance at the initial visit. And I've been doing that, with the ADHD medication and benzodiazepines. I don't prescribe opioids. Could I make a couple of other comments, if you don't mind?
Yes, please.
Because I would hope, as you mentioned, it's to be conversational. First of all, one of the complications is that seeing out-of-state patients. Pennsylvania gave me a temporary license so I could see their people only 20 minutes north of here, but that's not going to go on forever. If one of my patients goes to California and gets into a crisis, I can't provide services in California. I'm not licensed in California. My guess is it's a law that's probably broken pretty often. And part of there's a big difference between a bill in front of Congress and an act in Congress. But the bill provides for federal leniency in seeing people out of state. Right now, it's on a state-by-state basis. One of my prospective patients went to Arkansas, and I just could not get the answer about whether they would let me do it or not. They didn't answer my phone calls, and I just said, the patient, I can't see it. And that happened again with a prospective patient who was in Florida. So it's created quite a few problems, and we'll be creating more problems in the next few months, because that's how, the natural tendency of the universe is towards disorganization. This invites the question, why didn't we do telehealth beforehand if it was so blankety blank good? My son does telehealth and was doing it long before I did it because of the pandemic. And I worried about him because I worry about the suits. One, Muhammad Ali was the one who commented that everybody has a plan until it gets punched in the mouth. And we haven't seen that so far, but we will, is my prediction. One punch in the mouth would come from a plaintiff's attorney pointing out, when did you last see the patient who committed suicide in person? And the answer is, I never saw him. And then they'll move for what they call a summary judgment. In a malpractice case, you have to show, the plaintiff has to show a preponderance of the evidence. But in a case called res ipsa loquitur, the fact speaks for itself. Once the judge decides that, you have to show by preponderance of the evidence you were not negligent. It can create a lot of problems. And the last thing I want to comment is I'm the editor of 2 journals. One is for the Southern Psychiatric Association, and the other one is for the Maryland Psychiatric Society. And 2 lawyers wrote a column for the Maryland one about why you shouldn't treat family members. That was fine. In the next issue, they wanted to write one about all the regulations about telepsychiatry. And they had 13 things you had to say, like every session. They said the board in Maryland is contemplating 5, but just because they're lawyers, they threw in another 8, if you know what I mean. So I told them I not only had never seen this, but I would never go see a psychiatrist who was that obsessive. They said, well, you could send it in advance. I said, I wouldn't keep the first session. They said, well, you could say it in the first session. I said, I wouldn't return for the second session because there's no blank time to even see what's wrong with the patient. They're spending 13 things, easily take up, what, 25-minute session, an hour session? And you know, if you give them 13, they'll make it 15 next time because that's what lawyers do. So for one of the few times in my career as editor, I just told them I wasn't going to print it. They said it's guidelines. And I said, yeah, and the plaintiff's attorney get a hold of it and they'll call them standards because I know they're doing guidelines and standards, but the jury won't. And that's going to be a real problem because things will go wrong. They always do. And when they go wrong, the protections are not in place yet. And that's what I'm worried about. If it was so good, we would have been doing it all along, you know. It's not as good, by the way. When I see a new patient in my office, in the barn, when the dog comes over and licks the patient, and then we have a pond and they see the cows and the chickens, there's a certain ambiance that is not the same thing as when they see me on camera in a room in my house. That's all I got to say.
No, lots of great points. I mean, I think the first couple points about out of state and when patients move, I mean, that's been a huge issue here. And the question comes up for us is, you know, obviously during the COVID, as you say, states have allowed for emergency, you know, privileges in states. That's gone away pretty much a lot of the states now. But but also I think it led to these situations where UNC, for example, you know, we see a lot of students who left, right, as COVID hit and they went back home. And so then it raised a lot of concern amongst our providers about patient abandonment, you know, and what is our risk with patient abandonment versus treating people across state lines where we're not licensed. And so there were a lot of meetings with risk management, et cetera. UNC kind of came down with what I thought was a bit of heavy-handed policy, but when we pushed them on it, they basically said, you know, do what you think is right for the patient, but at the same time, you need to move as quickly as possible to transition them to care in a state where they're locally, or you can see a provider who's licensed.
Yeah, right.
So it's a big problem. I think I see what you're referencing here, Rachel, you know, about licensing requirements. And, you know, there is some of the Western states, you know, have gone to this sort of credentialing by proxy type situation, which for good reasons. I mean, they just have fewer providers to cover a huge area of land and population. So I don't know that that's going to happen, but we'll kind of see what pans out there. And to your point about the, you know, there's the case law, you're right. Like there's just not as much case law out there regarding, you know, liability with telehealth. And yes, we are also given here are the things that you need to document in your note that you talk to the patient about and that they give consent and all of these things. And so I don't see that going away. I think we should push back on some of it, but I think because you're right, and over time it will evolve, and you know, eventually, I think some of it will be loose, will be given some laxity to it because of hopefully over time, we'll see, but you know, that we won't see as more negative outcomes with telehealth as you might see with you know, in-person care. I think to your point about is it as good, you know, we have moved in the department to try to have every new patient appointment in person, and for various reasons. We're going to adjust that now with Delta. I think so having the capability to shift back and forth is going to be key. But what we definitely heard from our providers is they really would love to have that first appointment in person. I think where it becomes more complicated is when we're trying to increase our outreach and ability to provide care to folks in rural parts of the state that it's too far for them to travel. They don't have transportation. So I think it's going to end up being a little bit of a mix, but probably for the bulk of the patients that we see here, we'll still have them come for a face-to-face visit initially. And there will be patients that our providers will say, you know what, I don't feel comfortable managing this person via telehealth. So great comments. Thank you. I want to talk a little bit about just a couple of things we're doing here at UNC, and then I would love to hear other people's experiences and thoughts if they have them. One of the big areas that we have tried to develop some programs around with telehealth, getting more logistically, having more logistical capability to do this and more support for it, is can we move into spaces that were largely underserved. And in North Carolina, that's the biggest area is in child and adolescent behavioral health. So, North Carolina, depending on which ranking you look at, we rank somewhere between 44th and 50th out of 51, including the District of Columbia, in terms of access for behavioral health care for kids. And so we have put forth a couple proposals, one of which has been funded to try to expand telehealth access for kids in rural parts of North Carolina. One of which will be a school-based telehealth program. So can we increase access by meeting with children while they're at school, which reduces some of the barriers to care in terms of transportation, parents getting time off work, et cetera. There's already school-based health programs in many schools in North Carolina. And so can we work with them to provide telehealth for behavioral health? This has been done in other places and is being done in parts of North Carolina, largely with counseling. What we are bringing to the table is also the capability to have psychiatrists involved, which, there are about 200 child and adolescent psychiatrists in the state of North Carolina, and they're located in 31 of the 100 counties. And not surprisingly, the vast majority of them are in Orange, Durham, and Granville County, where the state hospital is. So can we, leverage this to try to expand access to that psychiatric expertise? So that's one area we're really looking at. The other areas are in inpatient services, actually. So I mentioned earlier about virtual inpatient consultation to some of our affiliate hospitals. And so North Carolina now has 14 hospitals that UNC Health either owns or manages. And many of them are in rural parts of the state. We used to call community hospitals that don't have access to psychiatry expertise. And so what we're exploring now is, can we, build out a virtual consultation model to help support their inpatient medical providers who maybe don't have access to that care. So that's one area we're looking at. And then actually an area that's popped up recently is, North Carolina, UNC also has several now inpatient psychiatric hospitals that fall under its umbrella. And many of them have a difficult time maintaining psychiatrists. So can we actually support inpatient psychiatry beds with a virtual model, which, I don't think an entirely virtual model works. There needs to be people on site, but can we help support, let's say, an APP who's working on an inpatient unit to see patients? So this is actually an area that is being explored now, and the reason for that is severalfold. We have, a reducing. I mean, we're always looking for inpatient beds for people and try to get people out of our EDs. Excuse me, and we have some beds that are not staffed that could have patients in them. So can we help support those hospitals so that it serves the entire system by reducing some of the backlog in emergency departments? And then the big the big thing we're working on is, can we centralize some of these services into one, what we would call a hub? So maybe there would be a provider who is doing some virtual inpatient consults, but then they're also doing, electronic consultations, or, are they also providing support to an inpatient unit? So can we centralize services in a way that we can support a number of different initiatives with some, shared services, essentially? That's kind of where a lot of health systems are moving towards in this space. So we'll see how all that pans out. But that's kind of what some of the things that we're working on here now. So I've been talking for a long time. Hopefully this resonated with some people, was interesting. I'd love to hear other people's comments, thoughts about their experience. I feel like this is an area, I am responsible for how virtual care happens in our department. And I think people probably assume like I'm like all about it and we need to do more virtual care. And I think what I have, my position is like, I think it's a tool, and it's a tool that we have to use appropriately. And so, yes, we're going to look at all the opportunities that we may, in spaces we may use the tool with, but at the end of the day, it may not be the right tool for the job. And so that's part of my job too, is figuring out, is what we're doing working, or should we, rethink any virtual care strategy? So I'd love to hear other people's thoughts, comments.
Well, first of all, I was going to say thank you so much, Nate, for speaking today, because that was really helpful to learn your perspective and get some updates on what's going on at UNC. To piggyback on what you just said, though, is like, this is a tool and we might change, and a lot of that's navigated by patient preference and patient need. I do find it really interesting in my practice. I have so many patients who prefer it, whether or not it actually is in their best interest, right? If I do need to actually see them in person, it's too distracting for themselves to be at home, or to be a valuable visit. And what that looks like moving forward when people choose to forego the reimbursement process because of that, right? Which I know is a very small subset of clients. But with that said, I imagine that actually being the case for some of my folks, because it's just more convenient for them. And I see that a lot with kind of advertised people in the community who are individual psychotherapists, but also life coaches, and that they can kind of completely forego the licensure requirements from different states. It doesn't matter to them, but it's interesting that they're developing dual certification in that realm, so they can kind of use either hat depending on where patient's at and what patient prefers. So I thought that was interesting. And to be honest, I'm a little envious that we don't have a loophole scapegoat to kind of be safe on our behalf also. But to back up what was also said earlier, I do wonder how many people are legally or illegally serving clients the way that they need to anyways, whether or not they know it, right? But it's an interesting concept, and one that nobody individually gets in trouble for, but all of us as a...
Yeah. No, I think those great points. And I think to your point about demand, I mean, I do feel like, we're sort of the continued march towards healthcare as consumers of healthcare, as opposed to utilizers of healthcare, I think is just accelerated with the shift to virtual. And I think there's this expectation by a lot of people that, your healthcare should be as accessible as Amazon, right? Like if I go on Amazon, I can chat with a service representative and I can get everything I want right away. And so I think that there is going to be this tension, right? That people are going to want things that they want, and we are going to be in a position to decide, is that the right care to provide to them? And it's gonna be interesting to see where it shakes out. And over time it will. Like we already know, we see how younger people interact with healthcare and virtual care. It's very different from older folks who have a pattern that they're used to. So it is interesting. I mean, the one thing I do stress when I meet someone for the first time over virtual is, you know, I am going to treat this like a professional interaction, like we would if we were in my office, and I expect that of you as well. This is a professional interaction, and so you shouldn't be, you know, surfing the internet or, you know, ordering food or in the drive-through, which has happened before. So, you know, like driving a car, like the same sort of principles should apply. So do try to set that up, and you probably will lose clients, you know, as a result of that. But I still think it's the right thing to do.
I feel like I'm frequently finding myself in a position where I have to reinforce that that dynamic of I'm the physician, you're the patient. This is not like a consumer interaction. And they're like, you know, I have rights. And I'm like, you have the right to the best medical care that I can provide you. And so I need you to take this visit as seriously as I do. So you looking like you just stepped out of the shower, you've got a towel wrapped around your head. Would you show up in my office looking like that? Or like, oh, we can't talk about that because I've got all these other people around me. Well, when you logged in, you said that you were in a private room where we could have a confidential encounter. I had one person log in while they were inpatient. And one was in pre-op. They had all their surgical stuff ready to go. And I was like, this is really poor judgment on your part. If you cannot physically be in my office, you cannot have this visit. So we're struggling with that. We have people logging in from out of state, asking for, you know, controlled prescriptions to be sent wherever. And I'm like, sorry. And they're like, no, I have to have this medicine. I'm like, I don't think, you know, a couple of days without Adderall will kill you. But if it's really that important, I need you to come back to North Carolina. And they're like, I'm going to complain. And I was like, okay, I can't stop you.
Yeah.
It's, you know, everything has escalated. I think, you know, and we're seeing, you know, national trends of everyone being very upset over little things and escalations kind of happening really quickly. And we're seeing that in our clinic as well. You know, everything is like, I'm going to sue. Okay. Can't stop you. So our poor office managers had to do a lot of customer service type things. But again, the thing is, like, as physicians, we are responsible for a lot of things. So if you're not coming in for your visits and you're not getting your blood pressure checked, I'm still responsible for that. So we are encouraging people to come when it's appropriate. There is actually a decent percentage in my clinic, at least, where the video visits are completely appropriate because they're stable patients. They just need to check in with us. And they're on like 50 of Zoloft, you know, like that's fine. But I find that some of my more complicated patients, especially the medically complicated, they are circumventing the in-person visits. And I understand their fear and I get that, but I have one complicated patient who's been hospitalized 9 times in the past 18 months, mostly for medical reasons, but sometimes gets transferred to a psychiatric unit for continued care. And I have not seen them in person, and I feel like I'm missing something. And I've encouraged them to come in, and they just won't. And then they recently filed a medical board complaint against me, and I'm like, I've bent over backwards for you. I'm not really sure if this is justified, but it's escalating so quickly.
I think there's a couple, I mean, I would echo a lot of what you said. I think all of this transition, again, I said it before, like it's all with COVID happening, everyone is stressed, and everyone, the sort of intensity of emotions that are out there for various reasons are heightened. And so I do feel like there is the like switch to virtual health was embraced by everyone, a lot of people, I will say, early on, and then there's been pushback, and the longer that it's gone on, right, I think there will be more pushback by certain people, both directions. People that will want it and we don't feel it's appropriate for, and people who don't want it and will be asked to do it. So I think until we reach a state where it's a more natural situation where it's an option for people that we offer it to, we've talked internally about, like, do we default, as we talked about before, like the default is you come and see us in person, and then we will decide together if that you are, this is appropriate for you to have virtual visits moving forward. That's probably where we will move to for many of our patients.
Yeah, and I've seen positives too. I'm not, completely against it. We used to have maybe a 30% no-show rate, and we're down to less than 10% now. So we are certainly seeing more, which is encouraging. But at the same time, some of the value of those visits has gone down a little bit as well. So, there are trade-offs for sure. I have not found the phone visits to be worthwhile from either angle. I have really, really sick patients telling me that they're doing great. And I'm like, I don't think so. But normally, I miss my other senses, because I can tell if you haven't showered in a month. I can tell if you haven't combed your hair. But with a phone visit, I have to go by what you tell me, and you're not telling me the truth. So I have seen the telephone. We are heavily discouraging the telephone visits, and only doing it when you are scheduled for a video visit, and at the time of the visit, things just fall apart and we have to make that visit happen somehow. But in advance, we are not scheduling telehealth visits. Telephone visits. They're unhelpful. And in my opinion, meet standard of care.
Can I make 2 quick points? One is, my understanding is that your DEA number applies in any state that touches on your state. So in Maryland, for example, I can provide it for Pennsylvania. I don't need a separate number for that. Or Virginia or West Virginia, but I can't use it for North Carolina. So they don't have to come back into Maryland, but they do have to be in a state that touches Maryland. And secondly, doctors treat patients, we don't treat clients. There's a whole body of evidence about that. The word patient comes from to suffer, and it's not the same as being a consumer. A consumer eats up resources. The patient is due a certain consideration just because he or she is a patient. And I don't know to what extent psychiatrists are going to drive this. About 5% of mental health professionals in the United States are psychiatrists now, and the percentage is dropping. So my guess is that since every politician, as I learned years ago, has the ability to count noses, they'll pay more attention to the psychologists and other counselors than they will to the psychiatrists on this.
Great, yeah, that's a great point. I think I'm just being cognizant of the time. I really appreciate everyone joining in the discussion.
This is great. Thank you so much again, Nate. Your knowledge.
Thank you so much, Dr. Stower, for joining us tonight.
Yeah, absolutely. Take care. Stay well, everyone.
Bye. Thank you.
Bye-bye. Night.
Bye.
Bye.